appropriate follow-up to Dr. Cohen's beautiful talk, let me introduce Dr. Arlene Chapman, who is dedicated to improving the lives of patients with renal disease. Dr. Chapman studies personalized medicine and the role that genetics plays in predicting, for example, antihypertensive responses to blood pressure meds. Dr. Chapman has received continuous support for her work from the NIH over the past 18 years. She is the chief of nephrology here at the university and the director of the Clinical Resource Center for the Institute of Translational Medicine in the BSD. Dr. Chapman has published many peer-reviewed publications and book chapters, has served on the editorial boards for the American Journal of Kidney Diseases, Kidney International, the Journal of the American Society of Nephrology, and the Bucksbaum Institute is especially proud to have named Dr. Arlene Chapman as one of its master clinicians. Today, Dr. Chapman will speak to us on the topic, Recognizing Food and Water Insecurity in Patients with Chronic Kidney Disease. Arlene Chapman.
Well, thank you very much for the kind invitation to speak today. And just as a follow-up to the previous presentation, I graduated from McMaster University, which is a problem-based medical school. Didn't require science as a background for coming into the school, and it was a small group learning experience and peer-led in a pass-fail format. When the school first opened in Canada, the traditional medical schools predicted inaccurately that it would not succeed as a medical program. And it's actually been a role model for education and medical students today. So I think there are groups underway in advance of the adjustment age. Yeah. So I'm going to share with you some experiences we've been able to focus on in renal medicine, in most part thanks to the Bucksbaum Institute. And before I start, I want to share with you how lucky the section of nephrology here has been with support from this institute. So Drs. Tipu Puri and Milda Saunders have been supported in their endeavor to understand patient and physician education in chronic kidney disease. Dr. Anna Zisman has been focusing on fluid intake in patients with nephrolithiasis and polycystic kidney disease. Dr. Pat Cunningham has been supported to approach African Americans at genetic risk for kidney disease through APOL1 gene testing. And Dr. Michelle Josephson, a recent member of the Bucksbaum Institute, is focusing on organ donation and renal transplantation. So we're very, very fortunate, and we thank the Bucksbaum Institute for their support. And I think this is the kind of incremental programmatic support that can actually really change the direction and the impact on patients with a chronic medical disorder. So thank you very much. So this is a screenshot from a patient who was referred to one of our chronic kidney disease clinics for their first visit. And I want to show to you that a couple of things. There's multiple diagnoses on this person's chart. Someone accurately noted that someone had anemia that was associated with chronic renal failure before they came to the CKD clinic, but there's no CKD diagnosis. There is chronic kidney disease stage 3 below that showed up after the visit. And then inguinal hernia, status post-inguinal hernia repair show up duplicatively, and the type 2 diabetes and diabetes shows up duplicatively. So when we go in to see patients with chronic kidney disease and we talk to them about what they have and we tell them that they have a kidney disorder, oftentimes they're surprised. This seems for them to be the first time they're finding out that they have problems with their kidney. And they feel the same as they have for many, many years, and they want to know why now is the kidney a problem and what kind of a difference is it making for them. And it's a complicated discussion because we're about to embark on a lifelong journey with these patients to help them avoid the need for dialysis or transplantation. And I'm going to share with you that one of the things, many of the things we can do for these patients requires mindfulness about dietary food intake and mindfulness about fluid intake. And that's a daily ongoing process for patients with chronic kidney disease. So chronic kidney disease is a public health issue. There's a rising prevalence of this disorder, approximately 13% worldwide, and it's the 11th most common cause of death worldwide. Their adverse outcomes and mortality have almost doubled in the last 2 decades. And mortality is actually a competing risk for the development of renal failure in these patients. And I'll show you some information about that in just a minute. Chronic kidney disease and ESRD incident and prevalence rates in Chicago are one of the highest in the United States. So we are in a renal failure belt in this part of the country. So one of the ways to look at what happens to patients with chronic kidney disease in an unbiased format is to actually look at them before they see a nephrologist. And this is a study that was not done in the US, it was done in Italy, so there are some differences in the patient populations, but it's a large study with over 30,000 individuals. And what you can see here are the associated comorbidities that these patients have: hypertension, dyslipidemia, obesity, albuminuria, and anemia. And you can see their relative frequencies based on their stage of kidney disease. And so we have classically 5 stages of chronic kidney disease. Stage 1 are people with a kidney problem but with normal kidney function, meaning an eGFR greater than 90. Stage 2 is mild to moderate renal insufficiency with a kidney function of between 60 and 90. 3A and 3B are more advanced, between 60 and 30. Stage 4 is between 30 and 15, and stage 5 is 15, which is typically around the time that patients are getting ready to start dialysis or to be worked up and evaluated for a possible kidney donation. So here are these patients followed up over approximately 7 years, and you can see based on their stage what the incidence of ESRD is on the left and what the incidence of death is on the right by CKD stage. So the risk for death is 20-fold higher than the risk for ESRD. So when patients come to our clinics, they are at higher risk for mortality than they are for renal failure. They're very, very high-risk individuals. The other thing that you can see here is that those individuals with relatively mild renal insufficiency, meaning stage 1 or 2, are much more likely to never make it to ESRD or to require transplant. Now, it doesn't take away the risk for ESRD, and you can see on the left that those individuals with CKD stage 3, 4, and 5 have a very high likelihood of progressing to renal failure if they can survive to making it to ESRD. So we have a large population of patients that we really try to do interventions on, not just to reduce their mortality, but to reduce their risk for progression to renal failure. And here's where we get into some of the difficulties of trying to help our patients, because most of the associated quality of life or clinical effects that patients feel with chronic kidney disease don't actually fall into those diagnosable categories that I just showed you, such as hypertension or anemia or dyslipidemia. They fall into energy loss, they fall into loss of quality of life, they fall into sort of the diffuse loss of strength and energy that's associated with inflammation, uremic toxins, malnutrition, and hypercatabolism. And you can see along here the glomerular filtration rate is shown going down across the x-axis. And as patients go from stage 1 to 2 to 3 to 4 to 5, these symptoms increase with increasing frequency. And we actually have a diagnosis for this compilation of symptoms, and it's called protein energy wasting syndrome, or PEWS. We don't use this very much in our clinical work, and it's not actually an ICD-9 or an ICD-10 diagnosable code, but it's a very, very important documentation that puts these individuals at extremely high risk for death before they start dialysis. And so all of the complications in here include hypertension, anemia, malnutrition, secondary parathyroidism or bone and mineral disorders, infections, and decreased quality of life, as well as cardiovascular disease. So food insecurity plays a big role here. The broad definition of food insecurity is that a person's ability to access nutritious food. That's the broadest definition. NHANES has a somewhat more specific criteria that's used successfully in evaluating food insecurity in a quantitative fashion. And it's a question that in the last 12 months, did you or your household ever cut the size of your meals or skip meals because there wasn't enough money for food? And few factors impact diet quality as strongly as socioeconomic status, and it brings into call or play the contextual measure of poverty, the availability of supermarkets and grocery stores, transportation impact, energy intake, relative sources of protein, saturated fat, sodium, phosphorus intake, which are all associated with CKD outcomes. So when one looks from the NHANES data at the impact of food insecurity on the cumulative risk for renal failure or ESRD in chronic kidney disease patients, we see that there's a significant impact. So those with food insecurity most likely will progress to renal failure than those that are food secure. And this is the figure that's shown on the left. Conversely, those individuals who don't have chronic kidney disease, who are food insecure, actually do better. And this highlights the point that the kidney plays such an important role in disposing of what we eat every day, what we energize through every day, the acid loads that we have, the amount of fat and carbohydrate in our diets. And this slide may not show very well, and I apologize for this, but this is a meta-analysis of the impact of a healthy diet on mortality rates in patients with chronic kidney disease before they start dialysis. And the take-home message here on this forest plot is to look at the bottom, and this is a compilation of all of the studies that are available, and you see that there's a lower risk for progression to renal failure, or mortality, mortality, in those individuals with chronic kidney disease who have a healthy diet, either plant-based or reduced in protein and saturated fats. So this is a complicated conversation to have with patients, and it's a complicated conversation to have with patients depending on where they're coming from and the things that they deal with on a daily basis. So this is something that actually looks like to be a very modifiable thing that could protect individuals, but how do we actually do this in a way that doesn't overwhelm a patient or actually turn into something that makes them not want to come back to the clinic? So looking here at home, our food fragility can be also assessed through food deserts. And this is a proxy for food insecurity. And so food desert is an area that lacks access to fruits, vegetables, and other foods for a healthy diet. 14.2% of Chicago is shown here in red, is considered a food desert. 422,916 African Americans in Chicago live in food deserts. 77% of Chicagoans living in red are African American. And if you look at the distribution of these red food deserts in Chicago, they're almost all either in the middle or on the south side of the city. On the right-hand side here, you can see some of the different communities that are affected by food deserts. And the ones that are relevant to our CKD patients that we see here at University of Chicago include Chicago Lawn, West Englewood, Washington Park, and components of South Chicago. So there are a number of different communities very close to us, the patients that come and see us who are in areas where they really can't access the foods that they need to be able to make sure that they're safe and protected from the presence of chronic kidney disease. So this is another way of looking at the same data, and these are the people affected by food deserts in Chicago. Over 600,000, predominantly African American, and the Latino population here, even though it looks smaller than the white population, it is disproportionately represented. Young individuals, disabled adults over 20 years of age, disabled children under 18 years of age, and single women with children who are under 18 years of age. So very, very vulnerable populations are also affected by food deserts in our city. So what about our patient populations and the unique here at the University of Chicago? So we looked through our census for the year 2017 and identified unique CKD individuals who are receiving care at our institution. So that may not be our entire patient population, but those are the individuals who made it to our clinics in the year 2017. And we have approximately 2,887 individuals with CKD stage 3, 877 with CKD stage 4, and 341 with CKD stage 5. And these are not individuals who necessarily are seen in the renal clinic. They just come to our institution for care, and we know based on their serum creatinine data that they have CKD stage 3. And when we tally up all of these individuals in the 16 zip codes that account for 85% of all of these patients, half of these individuals reside in food desert zip codes or communities. So how to approach this is going to be very, very complicated, and we're just starting now to try and figure out ways to deal with this, and this is where the Bucksbaum support has really been helping us. And we have Melanie Betts, who's just joined us as a dietitian, to really help us try and understand how can we actually understand what the food intakes are, what the food requirements are, and what are we really going to need to be able to make an impact. So again, if you look at the food deserts by TRACT within community boundaries, our UCM patients are shown, let's see if I can do this right. Well, if you, let me see. No. No. Okay. Well, if you look here through the sort of the middle part of the counties here, the numbers that would match up with us, Hyde Park is 41. And so right next to it is 40, 67, 69, 71, and 66. So this band sort of across that segment of the city of Chicago are where the vast majority of our patients come into clinic. And again, you can see there's very little at the very top of the city with regard to food deserts. So what are some of the challenges for improving the lives of patients with CKD that we can do through diet and nutritional input at University of Chicago? The challenges are that CKD is a silent disorder, and it's in the setting of a very comorbid state with many, many other medical issues that patients have to deal with. Risk factors for death and progression of CKD are competitive. And a lot of these patients don't make it to renal failure, and the ones who do are actually survivors. A lot of the medical issues that we're trying to deal with don't actually have an official diagnosis, and PEWS is a very good example of that. Potential therapeutic interventions are thwarted by the contextual poverty and food insecurity that our patients experience. And this is where we're really trying to come up with a satisfactory and successful way to help out. It's not easy to obtain accurate measurements of individual dietary intake through traditional dietary recalls or questionnaires. Patients may or may not like to engage in that type of questioning. And 24-hour urine measurements are very difficult to do. So we're currently working on imaging ways, patient interaction ways, community outreach ways to really start to try and tackle how to assess what our patients' dietary intakes are. So what are our solutions? Well, first and foremost, it's the patient, the patient, the patient. And they teach us a lot every time we talk to them about what they see as important and what they don't see as important, and how can we actually bring to the table what they eat on a daily basis to make a difference. Physician, trainee, and allied health professional education for the recognition and prioritization of CKD risk, I think, is sort of underrepresented in an underrepresented minority population. And so making an impact there is very important. Formalizing diagnosable risks for death in CKD patients and setting this up in clinics will be very, very helpful. And multidisciplinary ambulatory chronic kidney disease clinics with dietitian and social worker support are now being developed here at UCM to help with this. Community partnerships to help raise awareness, I think, will end up having a huge impact. And partnering with food purveyors, health policy, and city government may actually start to make a difference with regard to food deserts. So I'm going to swing away from that part of the issue of fragility on food and talk a little bit about the fragility of water. And this is actually moving in a different direction than lack of, but not taking enough of. And share with you some of the work that we're doing in smart technology with support from the Bucksbaum Institute. And this actually focuses on 2 chronic kidney disease patient populations that are truly a little different than the general picture that I gave you for chronic kidney disease. And these include patients with kidney stones or nephrolithiasis and patients with hereditary kidney disease called autosomal dominant polycystic kidney disease. And these 2 groups of patients, either by their means or by their keen interest because of the genetic nature of their kidney condition, are highly motivated individuals. So they're quite different from the larger group of chronic kidney disease patients that I shared with you at the beginning. Kidney nephrolithiasis, it's common and costly. It happens in about 10% of the general population. It's expensive and it's recurrent. With a third to a half of individuals will have their first stone will develop recurrence in the next 10 years. And one of the key features for caring for these patients is to increase their fluid intake, because low urine volume is one of the greatest risk factors for stone formation and recurrence. On the other hand, polycystic kidney disease is the most common hereditary kidney disorder and the 4th most common cause of renal failure. And it turns out that the hormone that regulates water intake and water excretion by the kidney, vasopressin, actually drives cyst growth in this disorder. So we have 2 separate chronic kidney disease conditions that probably can be modified through increases in fluid intake. So we were very fortunate to be given support for a pilot study, which is called Water, 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 a secret elixir and genie in the smart bottle, improving patient compliance with fluid intake, prescription with non-invasive hydration monitoring via smart water bottle, a pilot study. And Kendall Liu has been helping us with this. He's a University of Chicago graduate, and he'll be joining the Pritzker School of Medicine this July, and he's done a robust job at recruiting patients for this study. So this is the smart water bottle, and this is the phone that has technology to link with it through an app that's downloadable. The app itself will provide a number of different pieces of information, including date, time of day, the individual, and what the bottle is doing, and help give feedback to patients about how much fluid intake they've had during the day. And this is the type of data printout that can come from this approach. You can see that either by month, by day, by hour, we can see what patient's fluid intake is. And we can also see that there is a way to bank this by week and also by the fluid intake size at the time that patients take the fluid. So we wanted to use this as a pilot study to see how well patients would tolerate monitoring their fluid intake like this on an ongoing basis. And we also wanted to see whether or not, if we could use it, would it be any better than just talking to patients about needing to monitor their fluid intake and increase it. And the nice thing about this water bottle is that it glows. It reminds you when it's time. So if you've been prescribed 12 of these bottles to drink a day, it's geared so that on those intervals that will allow you to drink 12 bottles while you're awake, the light will go off to remind you that it's time to drink the next bottle. So what I'm going to do is share with you very briefly what the study design is and one patient's data, so you can get an idea of what happens when you actually do have technology to assist you in taking care of patients. So individuals with low urine volumes on a 24-hour urine were included and randomized to either receive standard dietary and fluid recommendations to increase their fluid intake to at least a goal of 2.5 liters per day, or the same types of recommendations plus the smart water bottle for 12 weeks. They were given a baseline questionnaire on their fluid habits and lifestyle, and this was repeated again at 6 and 12 weeks. And then we repeated their 24-hour urines at 6 weeks and at 12 weeks in both groups to see if there was any impact. So this gives you an idea of one of our more motivated individuals who has hereditary kidney disease and was asked to drink 4 liters of fluid a day. And you can see documented out of the 82 days of her participation in this study, she far exceeded the goals that were outlined for her. And again, I'm telling you, this is a very motivated patient population, right, who have many family members who've been affected by the disorder. They're very keen to learn about ways that they can impact their disease. So this is not your typical chronic kidney disease patient population, right? But at least in terms of monitoring whether or not we can track what someone does, it shows very helpful information in terms of whether or not we're getting to the goals of therapy that we wanted to reach. This gives you an idea of another individual who had a target goal at the end of 6 weeks with a water bottle in addition to the recommendations, which they didn't quite meet, and then at the end of 12 weeks, where they were able to reach their goal with feedback and information from the water bottle that they had. So here is an outline of a compilation of hourly fluid intake for all 82 days. For an individual who participated in the study. And so both for the purposes of preventing crystallization of minerals in the urine and also to prevent any proliferation of cystic epithelia, we want to try and keep fluid intake high and constant as much as possible. Obviously, when someone's asleep, that's not going to be possible. But while they're awake, we would really like to see them keep their fluid intakes to the point where neither crystal will occur nor a cyst will grow. And so this is one way that we can use this technology to actually help us see if we're able to do that. So this is the data shown here for what percent drank during each of the hourly inputs, also what the mean volume that was taken in over the 82 days. And this is now shown here in graphic format so that you can see while this individual was asleep, there was relatively little fluid intake, and really there's not much we can do about that. But for most of the waking hours, their hourly fluid intake was well above 400 ml per hour. And we know that that's sufficient for us to inhibit both the crystallization and the proliferative propensity of cysts in these individuals. So I can tell you at least personal feedback from the individuals who use the bottles that one of the comments is, well, it is kind of a love-hate relationship. You know, this is a little bit of a technological impediment that's carried around with me, and I'm thankful that it helped me to keep my fluid goals, but it's always there, right? So I think we're learning a lot from this pilot study in terms of feasibility and practicality and long-term use, and I'll be very excited to share with you the results when the study's done. So thank you very much to the Bucksbaum Institute for your support and encouragement.
Thanks a lot, Arlene, for a wonderful overview of the challenges of taking care of our patients. But I'd like to bring up a brief controversy about the food deserts. You may have seen that there was a report that came out from our Booth School that suggested opening up good grocery stores in a food desert did little to change the nutrition of the people who live in those food deserts. And so it's clear that just opening up access doesn't really help. It seemed to bring to my mind that really we have a job to do, and that is to then educate our patients on what are the good choices. So I would like your comments about how in the clinics we can try to introduce these good, healthy food concepts to our patients, and how can we teach patients to take part in improving their nutritional intake.
Yeah, no, that's a great question. I mean, I think the first step is to really aggregate as much information from our patients as possible, because I think what patients often do through fast food as a mechanism for food intake happens whether they're in a food desert or not, right? And so understanding that fully, I think, is really the first step. And I think that's where dietary support, nutritional support in the clinics really make a difference. And I think we're still at a learning point. What I've seen not work very well so far is to walk in just with a bunch of recommendations to patients on what to do, because they're already in a situation where they're not really facing their days easily on an ongoing basis. And they may turn to poor food choices, not because they even have to, but because it's representing something else for them. So I think really getting an understanding of what they do and why they choose to do it that way, and what stops them from having healthy food choices, I think is our first order of business. And then I think we can actually think of ways to help these individuals. I would imagine, I'm sure if a Whole Foods was put up beside a couple of these homes, no one would go in there, right? So I think, how do we do this in a way that's culturally sensitive? How do we do it in a way that represents something that's a part of their life and culture, is going to be a more complicated thing to do. I do think healthcare reimbursement misses the point that, you know, putting money into a community worker is actually cost saving. You know, where someone actually goes into the homes and helps people want to do things a little differently for reasons that are important to them. And the cost savings and the life savings are huge, at least in this patient population. So I think the first order of business is for us to very carefully and systematically get an understanding of what the patients really need. Yeah.
Thank you very much.
Welcome.
My question is about
I have a microphone.
the role of the media.
Here you go.
Oops, sorry. Thank you very much. I'm coming from, I grew up in a different world and I came here. And when I was in medical school, we were formed to go to rural areas to teach people about how to prevent certain diseases and stuff like that. And we go there every week. One day every week. That's your job as a medical student, to go and you assign the family and you help them to get to the medical centers and so on. So what is the role of the media in the United States, in Chicago? And what is the role of the medical schools in Chicago in helping people who live in deserts, in educating and teaching? And at the end of the day, we have them having kidney disease and kidney failure. Where can we really do a good job to prevent reaching that stage? Thank you.
Yeah, no, that's a great question. I think University of Chicago Medicine does a good job of having community outreach programs, and clinics that are in neighborhoods that allow people who have a lot of barriers for access to care to be seen. I feign ignorance on this part, but I don't think there is at the medical school level or trainee level home visits per se that are done in the community. And one could argue, there's enough problems in the city of Chicago that are in the context of poverty that wouldn't be a bad thing to think about doing, both at the training level and at the physician care level. The media per se, I'm assuming what you're getting at is either through smartphone data packs or through news and coverage through televisions. Even though there has not been shown to be a racial divide in terms of cell phone use, there is a pretty significant divide when it comes to data pack availability. So even though there's no difference in terms of cell phone availability, the types of cell phones that a lot of these patients have don't lend towards media exposure for them at all. And that is a huge divide. And that was work that was done here at University of Chicago a couple of years ago through the neighborhoods around here. So, is it worthwhile to provide that type of resource support to individuals? Maybe. It's a fairly significant ongoing cost. But I'm not sure how much media, maybe because it hasn't been able to impact patients, has had a role.
Arlene, thank you so much.
Yeah.
In that incredible case you showed of 80 days averaging 8 to 10 liters of fluid a day, I was just curious, two things. One, the frequency of urination, and second, whether it changed electrolytes at all.
Yeah. Yeah. So the beautiful thing about the kidney, right, is that it can bring almost everything back into homeostasis, right? So you can drink beyond 12 liters of fluid a day and your serum sodium can remain normal. Yeah. So yeah, the kidney is a beautiful organ. It really is. As far as her having to go to the bathroom, yes, she had to go to the bathroom probably every hour or every other hour while she was awake, and she got up a couple of times in the night. Yeah.
Any other questions? No? Good. Thank you so much, Arlene. Thank you.